iliotibial band contractures, or there is a paralysis of the quadriceps muscles and the hamstrings are working. And if the bicep femoris is more strong, then they may go into a genu valgum, and external rotation deformity also develops at the knee joint. Treatment is, if the contracture of 15 to 20 degree or less in young child, it can be treated with posterior hamstring strengthening and capsulotomy. If more severe contracture, usually requires a supracondylar extension osteotomy of the femur. If there is a severe knee flexion contracture, division of the iliotibial band and hamstring tendon combined with posterior capsulotomy. A skeletal traction after surgery is given, where one pin is passed from the distal tibia, the second pin is passed from the proximal tibia. You apply 2 tractions to avoid posterior subluxation of the tibia. If there is a quadriceps paralysis, then you require some tendon transfers for extension of the knee. If hamstrings are also paralyzed, usually no tendon transfers is required if the hamstrings are also paralyzed, because once the hip is flexed, gravity flexes the knee and patient can walk forward. The prerequisite for a hamstring transfer is good power in hamstrings and hip flexors, gluteus maximus and gastrocnemius. Triceps transfer of bicep femoris has been most successful. What you do is, when the hamstring muscles are normal, they can be transferred anteriorly to the patella and ligamentum patelli to provide extension and stability of the knee. Transfer of both the bicep femoris and semitendinosus is a procedure of choice. They are brought forward, attached to the patella. After treatment is, you give a cast, long leg cast in neutral position. Genu recurvatum, knee is hyperextended. Usually it leads to 2 types of deformity. One is bony or structural changes, another is only soft tissue involvement. If there is bony involvement, the prognosis is better because you can do certain correction, and they can be done by osteotomies. So you do either a closed wedge osteotomy or a domes osteotomy or an open wedge osteotomy, you correct the deformity. But if it is type 2 where only soft tissue is involved, the prognosis is less certain after correction of this type of deformity. Usually a triple tenodesis is done, where the hamstring, you cut the gastrocnemius, you cut the semitendinosus and gracilis from its musculotendinous junction, you make a tunnel in the tibia, you make a tunnel in the femur, and then you pass this from the tibia, from the femur, and then you make a strap from the bicep femoris. Of course, the capsules are also advanced and they are sutured with knee in 20 degree of flexion. So this is the triple tenodesis for quadriceps weakness, so that it doesn't subluxate basically. In a flail, knee is unstable in all direction, so treatment is usually you give a long leg brace for locking knee and you carry on like that. Otherwise, you have to go for an arthrodesis of the knee joints. The various techniques for arthrodesis may be a Charnley's compression clamp, you use it as a compression orthodesis, or you use an intramedullary rod fixation or a plate fixation. Deformities of foot and knee, you see that this is an Egyptian painting which shows the post-polio-residual paralysis with equinus deformity. The deformities most commonly seen at the level of the ankle and foot is equinus deformity, valgus deformity, cavus deformity, varus deformity, calcaneus deformity, and there can be a combination of all of these which may be present. Now, principle of surgical treatment usually consists of correction of the deformity, correction of muscle imbalance, and correction of instability if present. So you have to consider whether it is a complete paralysis or an incomplete paralysis. If it is a complete paralysis, orthosis with minimum surgery. If it is an incomplete paralysis, surgery with minimum orthosis has to be given. Now, if you consider the age, if the child is less than 4 years, usually you avoid tendon transfer. Before skeletal maturity, you avoid orthodesis, except you can use an extra-articular subtalar arthrodesis or a dorsal wedge osteotomy from the calcaneum or IP fusion in modified zones. Surgeries are usually performed in chronic stage. The deformities which are seen in foot and ankle may be dynamic, may be static, or may be both. If they are a static deformity, you can just treat it by brace in a growing child, and adult, you do an arthrodesis.
Dr. Asif, please stick to the time. Times.
Actually, the hip, knee, ankle, and foot, it is a big topic. So, in a growing child, dynamic deformity, you will require a tendon transfer. In a growing child, recurrence is possible with arthrodesis. If child with a static deformity, recurrence after arthrodesis is rare. Now, suppose there is an equinus deformity, early stage, it is a flail ankle, you just do a subcutaneous stenotomy. If the dorsiflexors are paralyzed, you do a tendon transfer, most probably tibialis posterior is transferred to the midfoot, and you lengthen the tendoachilles. In the surgery, in a late condition, you do just an ankle and subtalar posterior capsulotomy with lengthening of flexor helicis, flexor digitorum, and tibialis posterior. If the dorsiflexors are not available, you just do a lambrinis arthrodesis, or sometimes you may require a triple arthrodesis. If it is a valgus deformity, because both the inverters, that is the tibialis anterior and tibialis posterior, are not working, the valgus deformity develop. If the child is less than 4 years, brace with shoes have valgus insole and crooked elongated heel. If more than 4 years and no tendons available, you go for an extra-articular subtalar arthrodesis. If further 4 years and tendons are available for transfer, you transfer peroneus longus to midfoot and extensor helicis longus to first metatarsal. Extra-articular subtalar arthrodesis may be done if it is not balancing that. In a flail foot and ankle, you do a subtalar fusion. In a tendon available for dorsiflexion is there, then you do a triple arthrodesis with tendon transfer. Calcaneus deformity, paralysis or weakness of gastrocolius with tibialis anterior overactive. When gastrocolius is grade 2, all transferable tendon, commonly peroneus longus, tibialis anterior, they are transferred to calcaneum and tendoachilles plication is done. When tibialis anterior is grade 1 or 0, the peroneus longus to calcaneum and tendoachilles plication to fibula under tension is done. Late surgery, ankle and subtalar fusion with correction of deformity. Cavus deformity, very commonly seen, they develop this with all these kinds of deformity because the peronei, they pull the muscles at first metatarsal and lead to cavus deformity. Releases, plantar release, surgery is in form of plantar release, or you do a Japa's V osteotomy to correct the cavus deformity. If the tendon transfers done for cavus deformity is, the dorsiflexion is weak, peroneus longus is transferred to midfoot and extensor helicis longus to first metatarsal. If peroneus longus is weak, extensor shift to middle cuneiform and EHL to first metatarsal. Peroneus longus to calcaneum with tendoachilles plication or calcaneo-valgus, calcaneo-cavus foot.
So may we request to sum up, please, sir.
Varus deformity is not very commonly seen with polio. The bony procedures that are done are calcaneal osteotomy, extra-articular subtalar arthrodesis, triple arthrodesis, and ankle arthrodesis. Of course, the prevention is better than cure. Just a few things about post-polio syndrome. It is experiencing new weakness, fatigue, and muscle pain more than 10 to 15 years after a good recovery of function following initial poliomyelitis. The causes are not known. Most probably it is because of overuse phenomena or overwork phenomena. And basically, you treat it by reducing the relative muscular demand, muscle strengthening, shortening duration, and substitute device like orthosis, or you might require to do a correct release of contractures. Thank you.
Thank you, Professor Nair, for your nice presentation. Now I'll request Professor N. Verma. Sir, kindly deliver a lecture. He will deliver a talk on cerebral palsy, examination, and trends of treatment.
Sorry, next. Sorry, pen drive.
Thank you.
Pointers.
Good morning, everyone. I'll be speaking on a subject which has been neglected. Nobody wants to treat, and people want to refer them to their best friend because it is a very complex problem. The results are unpredictable, and often these children, spastic children, are left to beg on the streets or in some institutional like Cheshire Homes or Nirmal Hriday, they are kept there. However, with the wane of polio, cerebral palsy has taken over, and you see a lot of spastic children on the streets. The incidence is increasing. In 1860, William Little wrote the first medical description of a puzzling disorder which was called Little's disease for many years and is now known as spastic diplegia. Cerebral palsy term was coined by Sir William Osler, a British physician. Cerebral palsy encompasses a heterogeneous group of non-progressive muscular disorders caused by injury to the developing brain. What is an appropriate definition in the modern context? A permanent disorder of movement and posture due to non-progressive disturbance in the fetal or infant brain from prenatal period to 3-year period, postnatal period. This, I think, is a suitable definition for cerebral palsy. It is a condition, not a disease, a group of neuromotor disorders. It has a very high incidence in low birth weight children and premature children. And with better resuscitative measures, these children are now surviving, so the incidence of cerebral palsy is increasing. It's the most common childhood physical disability because polio is now a thing of the past. The motor disorders of cerebral palsy are often accompanied by lots of other medical problems, and more than 60% children have a normal IQ. Remember this, more than 60% of the children have a normal IQ. And if you can rehabilitate themselves, make themselves independent, they become useful members of the society. So it's a social obligation on us also to start treating cerebral palsy. The severity of the lesion ranges from a sectored defect to a global brain affection. The central control of muscle function is affected for the whole life. The immature brain attempts to heal itself but falls short, and the result is a fixed anatomical deficit. However, disabilities can be static, progressive, or regressive depending on the influence of the interventional modality of treatment and the muscle imbalance. This is the incidence, 6 to 4 per 1,000 live birth. The total population of cerebral palsy, a rough estimate in India, is around 30 to 35 lakhs. Imagine the magnitude of cerebral palsy children, and is the the motor disorders are often accompanied. This is, of course, it can present in various manners. Infants like this, various manners. And the spectrum of presentation ranges from clumsiness in gait to severe disability. The clinical classification according to the site of lesion. Spasticity, this is about 70 to 80%. Dyskinesia, ethetosis, chorea, balismus, tremor, dystonia, all this. I'll be covering only this part because orthopedic surgeons are concerned with this primarily. This is the topographical classification according to the extent of brain lesion. It can be hemiparesis, it can be monoparesis, it can be diparesis, it can be triparesis or quadriparesis. Hypertonicity, rigidity and spasticity. Contracture and deformity, muscle imbalance between agonist and antagonist muscles, mass movement, weakness of anti-gravity muscles, abnormal movement and postures, difficulty in coordinated and alternative movement, impaired body balance, difficulty in keeping the body in anti-gravity postures, and lack of fine motor control. These are some of the presentation of the associated medical disabilities. I'm not going into that, just skipping it over. This again is the Now, what is the prognosis? Examination, as for any other joint examination, and I think Dr. Nayyar has covered it in detail. So, with early intervention, which more than 80% of children can be given an acceptable life in society. Remember, 80% of children can be given an acceptable life in society. The quality and survival of CP with ambulatory capabilities, with or without walking aid, is roughly equal to a normal population. They can work, even with walking aids, equal to a normal person. In fact, their output can be more than a normal person, given the Indian scenario. Can be active, they can have jobs, live independently, marry, have children, and retire. Imagine, if you can give them all this, how are they different from a normal person? In no way. It's a clinical examination is the diagnosis. No investigations except blood investigations, and this is important. Genetic analysis, but difficult, not available in centers to rule out genetic causes in patients with family history. The commonest clinical presentation is mental retardation, speech defect, a drooling of saliva, scissor gait, crouching, that is flexion of knees, and equinus of the ankle. Remember, we are in Agra, near Mathura. And if you go back, Krishna had a friend Sudama, who was a spastic. That is the one of the things. And Sudama led a normal life. See this. Now what happens as the child is standing with support? A scissor gait, a cross leg. He cannot walk in this posture. If you can correct this, he can have a normal life. So, the management. This is the most important part, and I wish the postgraduates pay attention and follow this. There is no cure for cerebral palsy, as the brain damage cannot be repaired. The aim of treatment is to increase the patient's assets as much as possible and minimize his deficit. You have to use the patient's own assets and minimize the deficit. The earlier treatment in 19th and early 20th century, management of CP was by temple phase regime of treatment. I'll come to this temple phase in just on the next slide. In the mid-20th century, physiotherapy in the form of coordinating and relaxing exercises. Still important. Hand-brain coordination. Hand-leg coordination. A very simple example. You encourage the child to play football. Every child plays football. But have a ring and ask the child to hit the football through that ring. That's the brain-leg coordination. Then this, just mentioning partial total neurectomy and selective lengthening of tenotomy of tendons. There was another thing which came up in the 70s and 80s, stereotactic surgery. That is, you identify the focal lesions in the brain and coagulate them. The basic principle, we have an integrated, the modern treatment is an integrated approach. This is the present regime. Early intervention, a multidisciplinary approach, use of all available proven modality of treatment, prevention of permanent consequences, and early treatment of any unwanted consequences, assisted devices, training and counseling of patients, and life planning. This is an integrated approach of treatment. How do we go about it? If you can identify that this is a potential CP patient, a child, premature child, born crying late after birth, treat it as a potential CP. Normally, these infants would not have survived, but with better resuscitative facilities in NICU, they are surviving, and therefore you have an increase. So, how do you diagnose? CP is likely if there is no head control after 3 months, sitting after 6 months, rolling over 18 months, and walking 18 months. The abnormal behavior, excessive docility or irritability, poor eye contact, poor sleep, oromotor problems, and all these things. These help you in diagnosing CP in an infant or suspecting CP in an infant. The pediatricians say that CP should not be diagnosed before 2 years. You can only write delayed milestones. Why? I don't have the reason. So early identification in a high-risk child, post-discharge follow-up, proper therapy at the earliest, 3 to 6 months. Sensory integration, more than 80% children can have a normal life with early intervention. Deformities in CP. Primary deformity due to muscular imbalance and spasticity. This is in about 80 or 90%. Then secondary deformity occurs due to spasticity plus bony changes. You have got 55 to 60%, 65% success. And tertiary deformity, spasticity, bony changes, plus adaptive postures like crouching, genu recurvatum, etc., a difficult problem to treat. Do not allow your patients to go into this stage now. So this is a new branch which has come up. Developmental pediatrics. I'm not going into details, but for management of spastic child. You stimulate the development of certain reflexes in a child which otherwise would have come normally. Positioning and carrying. This is important. A kangaroo mother care. Nurse the infant like a kangaroo nurses its baby. This is the best posture to prevent disabilities and deformities. Proper handling, tone management, sensory motor stimulation, oromotor stimulation, assessment for future. So this I'm not going into detail because I don't know much about this myself. But it's a new branch and is very useful. You can reduce your disabilities and treat the patients well. The secondary modality of treatment is the traditional method, inhibitory plaster, nerve block, neurectomy routine. Now, this is still useful, but not much. Now, this is useful. 6 years, 2 to 6 years, toxins, botulinum toxin. Then you can have OSSCS, orthopedic selective spasticity control surgery developed by the Japanese. Then you have some single event multi-level corrective surgery. Earlier surgical intervention is necessary to restore the lever arm and tendon transfer. And this is another SEMLOS, which is a combination of this and this. Single event multi-level orthopedic spastic stabilization surgery. Now how does this toxin act? Given at the site of condensed neuromuscular junction in affected muscles, it causes focal dose dependent temporary denervation of muscle for a period of 4 to 6 months. Right? During this 4 to 6 months, you can stretch the muscles, you can correct the joint deformity and brace it. So this side effects are very rare, so you can try it. You can try once or twice also and achieve a reasonable success, especially in 2 to 6 years. Then you don't require anything except braces and rehabilitation of the child. Now, routine orthopedic surgery was a single, 2-level or multiple level surgery, repeated surgical intervention, late surgery, TL lengthening, adductor tenotomy, hamstring lengthening, all these were done when I was a resident. Even neurectomies were done, but it is not helpful in severely affected patient, and balance of tone and spasticity is not possible. And sometimes the condition became worse. Tendo-Achilles lengthening. Equinus deformity. Everyone says tendo-Achilles, equinus, do a tendo-Achilles lengthening. No, in CP it is not done because it produces a recalcitrant calcaneal deformity. Instead, gastrocnemius lengthening is done. The muscle fibers are not lengthened because they are elastic. They can be stretched. It is the myofascial covering which is contracted, which has to be cut. It is the aponeurosis which has to be cut. Incomplete, partial fasciotomies and then stretching will be able to correct the deformity. You retain the power of the muscle. You take away the deforming forces of contracture and you have a functional joint. Right? This does not reduce the strength of the muscle while overcoming the spasm. And balancing of muscles is also useful. How this balancing is done, I'll just give you an example. You have a flexion deformity of the knee. You correct the hamstrings at the knee level, while correct the semimembranosus near its origin, around the hip. So this will balance. Another method of balancing is half a tendon transfer. It has picked up recently and is very useful. Half the tendon transfer, half of peroneus, half of tibialis posterior for inversion deformity can be transferred onto the lateral side. So it will balance, reduce the force on this side and balance on the other side. Now this is a one basic principle. Monoarticular muscles have anti-gravity functions and they support the body to be upright. So it is these multi-articular muscles coexist in the human body and they are the culprit for hypertonicity. Muscles acting across two joints are responsible for deformity. Muscles acting across one joint are anti-gravity muscles and help to maintain the erect posture. Selective lengthening of multi-articular muscles and preservation of monoarticular muscles. This is here. This is the meaning of this short form. Give rise to good balancing of muscle tones. Now, single event, multiple level surgery. More than 30 muscles are involved in a single step of gait. All of you know it. Repeated admission anesthesia has got a bad impact on the overall performance of the child, is financially more burdening on the patient's attendance, and the best results are if all abnormalities are detected before surgery. And even people have gone to the extent, we have also done in some cases, the upper limb, the lower limbs simultaneously requiring about 7 hours or 8 hours of surgery. But the results are much better. So early surgical intervention leads to development of walking skill and plateau of functional response with therapies completed by the age of 5 to 6 years, because this is the age for the child to go to school. If you can do it by this stage, the child has only lost about 1 year, because this is the normal entry. You adjust about the same time. The ideal age for surgery is 6 to 9 years, because the child can then cooperate with your balancing. Prevention of joint decompensation and overlengthening of tendon, permanent correction of deformity, good preschooling rehabilitation, better development of extracurricular activities. Single event, multiple level surgery. New concept. Solution to each children is different. Multi-level correction of deformity by concept of OSSCS along with lever arm restoration and tendon transfer. Balancing. In lever arm restoration, we correct the bony torsion by derotational osteotomy. Do not hesitate to do a bony derotational osteotomy to restore the lever arm. The tendon transfer helps in balancing of muscle tone, split transfer in foot, and correcting the muscle weakness in full transfer in wrist for a fixed pronation deformity and giving dorsiflexion. Some of the procedures, see, this is the deformity. Hip, knee. Again, this is the hip being operated here, all we have released. Rectus femoris, aponeurotic lengthening here, adductor lengthening here. The lower at the knee level, and here the balancing for the so all these lead to, this is the upper limb which has been operated. The integrated approach, just in a nutshell, 0 to 2 years, sensory integration, counseling of the patient, and coordination. 2 to 6 years, all these braces, botulinum toxin, inhibitory plasters also. 6 to 9 years, multi-level orthopedic surgical intervention, rehabilitation, schooling. 9 to 4 years, reassessment and continue therapy, schooling and psychosocial development. More than 14 years, final program of rehab along with surgical intervention if needed for some minor deformity. Now, this is the primary modality in physiotherapy. I think stretching exercises, joint mobilization. Sensory integration, these are the advanced. More of a physiotherapy, but help of physiotherapist, but you must have trained physiotherapy, a teamwork. Braces, very important to keep the joints in a corrected position. Articulated solid ankle foot arthrosis, supramalleolar arthrosis, but remember all this should be a lightweight polypropylene synthetic material. Slight modification in A4 design can correct. you can have a stops. And a plantar flexion deformity, equinus deformity, you can have a plantar flexion stop. In a flexion deformity of the knee, you can have a knee stop there. So these are some examples. 80 degree in genu recurvatum, 95 degree in dorsiflexion stop and crouch gait, medial strap in everted foot deformity, lateral foot strap. All of us who have practiced orthopedics before the A4s came, we used to give inside iron, outside T-strap, and all these sort of footwear braces for orthosis for CTV. We are aware, but remember, you must also be aware in CP. These are some of the polypropylene lightweight braces, right? Now, the traditional metal and leather HKFO, because it is very heavy, should be avoided. Go to polypropylene. This is useful. Single event, now what is the key message? Single event, multiple level surgeries to correct the deformities followed by splintage and physiotherapy are the sheet anchor in patients coming late. Patients between 2 to 5 years can be successfully treated with Botox injection and splintage and physiotherapy. Children between 0 to 2 years should be nursed in kangaroo position. Small games like building blocks requiring involving of brain and hand coordination should be given as a game, as a rehabilitative physiotherapeutic measure. This is where you can find more details. Thank you very much for your patient hearing. And I wish a few of you younger surgeons take up this challenging task, and I tell you the results are gratifying. In approximately 50 to 60% of cases, you can make these children a useful member of the society. Thank you very much.
Thank you, sir. Thank you very much, sir, for a very nice presentation. I will request Professor Alok Agarwal. He will deliver a lecture on principle of management of nerve injuries. As this lecture was scheduled yesterday by Dr. Amir bin Saber, but due to some unfortunate reasons, he was not able to come here. Now, Professor Alok will take this lecture.
So, principles in nerve repair. Before I just start the lecture, I'll just ask you people that how do you diagnose nerve injury? So, better tell me, how do you repair? How do you diagnose ulnar nerve injury?
Sir, first of all, with the clinical examination, there is ulnar.
So there is a Froman's test which is positive. Yes, there is a pen test which is positive. There is a CAR test which is positive. There is a GAVA test which is positive. And how do you diagnose radial nerve injury? Anyone raise your hands?
Wrist drop.
Yes.
Against the wrist.
So there will be a wrist drop. There will be difficulty in extension of the MP joints. There will be inability to extend and abduct the thumb, all three combined. Okay. And who will tell me how you diagnose a median nerve injury? So in the median nerve, you will be getting an Osner clasping test positive. There will be a pen test, and there will be flexural pollicis longus inability if you hold it. And treatment of बताऊंगा sir. And how do you diagnose axillary nerve injury? The patient will not be able to abduct the shoulder due to deltoid paralysis, and there will be loss of sensation in the autonomous zone for axillary nerve. And how do you diagnose the common peroneal nerve injury? So there will be a foot drop, a high stepping gait. So that is good that you people know the basics. I will start with the repair. So this is the structure of the nerve, a motor root, a sensory root with the ganglion combining together along with the autonomous communications, and this anterior primary rami is the peripheral nerve. We should know the concept of dermatome, which is the area of the skin supplied with the fibers of a single spinal root called as dermatome. Segmental dermatomal patterns are well preserved in the thoracic region, but not in the limbs. Migration of the limb bud accounts for the displacement of mid-cervical dermatomes along the lateral aspect of the arm and lower along the medial aspect. Same thing for the lower limbs, and the line separating the more rostral segments is called as the apical line. So these are the dermatomes you should know, because then you will be knowing which root is being affected. If you go for the macroscopic appearance before repair, So, there is a complete nerve covered by an epineurium, there are fascicles covered by the perineurium, there is a single nerve fiber covered by an endoneurium, and that is the axon, that is the nerve fiber covered by myelin laid by the Schwann cells and an outer basal lamina. So, if you know the structure, then only we can repair. One has to understand the internal topography of musculocutaneous nerve as shown here, or all the other nerves, that the nerve fibers are not going straight, that you repair them. You may repair them, but they are going in different directions, and that is why many of the repairs do not get full recovery. And you see here, then you find the more distal you go, you get a straighter arrangement of the topography, and more proximally it is more complicated. So, the results will be good if you are doing a repair here rather than in the proximal part. Now, these are the physiological changes in regeneration. This is the peripheral nerve, you are cutting it, see what happens. Distal to the cut, there is a Wallerian degeneration, there is a swelling of the cut ends, and for 1 or 2 nodes, there is a traumatic degeneration up also. Once you approximate it, there is an axonal budding from 1 week to 3 months, and at several months the nerve may regenerate completely. So, the purpose is to keep the both fragments together, that is the recovery. Now, how do we classify nerve injuries? Well, Seddon in 1943 classified them into neuropraxia, that is a local conduction block, and axontemesis, where the axon is cut within its sheath, and then a neurontemesis, well, all the sheaths are cut, and the recovery will be very difficult. You have know the structure here. So, this is in 1951, Sunderland comes with this classification, which is followed more. You classify them into 5 grades. Class 1 is like neuropraxia, class 2 is like axontomesis, and class 5 is neurontomesis. The myelin sheath is pressed in neuropraxia, but injured in the rest 4. The axon is cut in 2nd, 3rd, 4th, 5th. The endoneurium is damaged in 3rd, 4th, 5th. The perineurium in 4th, 5th. The epineurium is also cut along with the axon in grade 5, and so it is the most severe one. And a tinal sign will be present in grade 2, 3, 4, 5, but it will progress distally only in axontomesis and grade 3, but not in the other 4. So, a nerve when it cuts produces motor effects, sensory effects, and autonomic effects. So, motor power grading you people all know from M0 to M5. So, I will not go into the details. For the sensory one, you should know what is the autonomous zone, the area of the skin supplied by a single nerve without any overlapping. And so, the first web space is for the radial nerve. These 3.5 fingers tip is for the median nerve, 1.5 is for the ulnar nerve. The first web space in the foot is for the deep peroneal nerve. We should know them, or we should go through this chart to see how the things are following. Sensation assessment after peripheral nerve injury. This is important for you people. S0 means there is absence of sensibility in the autonomous zone. S1, there is a recovery of deep cutaneous pain sensations within the autonomous area. S2, return of some degree of superficial cutaneous pain and tactile sensibility with autonomous area of the nerve. S3, return of superficial cutaneous sensations, tactile sensibility with disappearance of any previous over responses. S3 plus, return of sensibility as in stage 3 with some recovery of 2-point discrimination, and S4 is complete recovery. So, by doing a sensory examination, you get to know how much is the recovery coming. Reflexes, if a nerve is cut, will always be absent. And autonomic, so interruption of peripheral nerve is followed by loss of sweating and of pilomotor response and by vasomotor paralysis in the autonomous zone. The area of anhidrosis usually corresponds to, but may be slightly larger than the sensory deficit. So, what are the tests for autonomic function? A starch iodine test, an anhydrine printing test, a registered dermometer which tells you about the skin resistance, and another objective test described by Orion and Lukens is the wrinkle test. You put the hand in water, there will be wrinkles normally, but if the nerve is cut, autonomic sensations are cut, there will be no wrinkles. And once the wrinkles are absent and they are starting to reappear, that means the nerve is recovering. Now, coming to the electrodiagnostic studies, they are required for documentation, location of the insult, severity of injury, the recovery pattern, for knowing the prognosis, objective data for impairment documentation, what is the pathology, and finally, if the nerve does not get repaired, then you have to go for tendon transfer procedures. The most common one is EMG and NCV, which tells us about nerve conduction velocity, axon or myelin involvement, and muscle recruitment capabilities. So, this is how you test. This is the proximal stimulation, this is the distal stimulation. Once there is a neuropraxia, you find there is no response to proximal stimulation, but on distal stimulation you get the response. While in axontomus and neurontomus, distal stimulation initially will not produce any effect, but immediately after the nerve being cut, there may be a response, later on again it ceases off. So, this is how you go for nerve conduction studies. If you do an EMG, this is a normal EMG before denervation, and you get positive sharp waves consistent with denervation at 10 to 14 days, and this is fibrillation potentials, which shows that now the recovery will not be there. So, the factors that influence regeneration after neuroraphy are age of the patient, smaller the age, better is the recovery, gap between the nerve ends, if they are in approximation, chances of recovery are more. Delay between time of injury and repair is important, because if the nerve ends have become into bulbs, then the repair will not be complete. The level of injury I told you, more distal, the better is the recovery. And then finally, the condition of nerve ends. If you have cut it, you may repair it better. If it is crushed, then you have to excise the segment. Recovery will not be that good, because the topography will be changing. What are the general conditions? When a sharp injury has obviously divided a nerve, early exploration is indicated for diagnostic, therapeutic, and prognostic purposes. Neuroraphy can be done at the time of exploration or may be delayed. When abrading, avulsed, or blast injuries are there, we do not know the condition of the nerve, and exploration is required for identification of the nerve injury, but you may go for a later repair when the wound is without infection. And when a nerve deficit follows a blunt or close trauma and no clinical or electrical evidence of regeneration has occurred, after an appropriate time, exploration of the nerve is indicated. This also is true when a nerve deficit complicates a closed fracture. And when a nerve deficit follows a penetrating wound, such as that caused by a low velocity gunshot, the part is observed for evidence of nerve regeneration for an appropriate time. If there is no evidence of regeneration, you have to go for exploration. So, what is the time of surgery? Primary repair can be done within the first 6 to 8 hours, but it may be delayed. Primary repair done in the first 7 to 18 days is appropriate when the injury is caused by a sharp object, the wound is clean, and there is no other major complicating injuries. A fracture is not a contraindication for operation. Operation before the fracture becomes united may be advantageous at times for nerve repair, because you may go for bone shortening, which is required for mobilization, and then an early repair and fracture, if treated together, then there will be no restriction of joint motion and muscular wasting. So, that is beneficial. So, what are the techniques available? If there is trauma, there is a bulb, you can go for endoneurolysis, and many times this endoneurolysis has to go with partial neuroraphy, where you excise it and do a repair. This is epineural repair. You can go for neuroraphy and nerve grafting if you cannot mobilize the ends. The methods of closing gaps between nerve ends are mobilizing the nerve, positioning of the extremity, by flexion you can bring it nearer, nerve transplantation, bony shortening, a bulb suture, you can go for nerve graft, and then nerve crossing, that is pedicle grafting. So, this is what we mean by epineural neuroraphy. You put a stitch on the epineurium, these are the fascicles and nerve fibers, the repair is complete. This is considered quite good, but we have to take care that there is no segment which was excised, because then the topography will be changing. They say if a single suture can hold the nerve together, it means mobilization was sufficient, otherwise a single suture will break. It means you have to still go for further mobilization, because if the nerve is in traction, it will go off. At times, when a gap has gone off, you can go for a perineural, that is fascicular neuroraphy. So, see, these are the fascicles and the sheath, the perineurium is being stitched, and that is how the repair goes. You can take a sural nerve graft. If a long nerve graft is required, you can go for long incision, so that minimum traction injury is to the graft also. You need not pull the graft separately, then it will not be functioning. and you know that it goes anterior to the lateral malleolus. And finally, you can go for interfascicular nerve grafting. If there are too many topographic changes, you have put grafts, and here you are doing the repair with the bone nerve grafts back in position. So the conclusion is, you have to identify the results of delayed primary repair have been considered better than an immediate primary repair because of the inflammation associated. Timings I have told you, younger age has got a better prognosis, and still by doing a proximal repair, there may be not a complete recovery, and you may have to go for tendon transfers, which you have to study. So this is in short principles in nerve repair. Thank you.
Thank you, sir. Thank you, Professor Alok, sir. Any queries? Yes. Mike, please.
Go for a Valerian degeneration or anything that is taken from other part?
It will go, but then I showed you in the first slide that once you go for a smooth cutting by a sharp knife, there will be a proximal degeneration for a few segments, distal, but you keep it in a position, immediately the nerve grows back. So that is the likelihood that it will grow complete. But then because of the topographical changes, the results have shown that at times you may not have a complete recovery. There may be sensory recovery, which I have shown you how it progresses, a motor recovery, how it functions, I have told you. And still, if there is an incomplete sympathetic injury, then the patient may develop causalgia. They are having the different treatment protocols.
What is the role of advancing Tinel sign in assessment of nerve injury? And my second question is, what is the duration when you will not consider or you will consider against nerve repair?
So the first question was a progressing Tinel sign. That is, you hit on the nerve's pathway and you see whether it is coming down or not. It shows that the recovery is there in a primary cut, which is recovering in a closed manner. So that is about Tinel sign, sir. So if it is progressing, then that is showing that there is recovery going on. Now the second question was, okay, when to stop thinking of the nerve will recover and go for tendon transfer. So you will go for EMG. And if the regeneration potentials are not there on the EMG, you are very sure that now this nerve will not recover. It is better to go for that. But sometimes in closed fractures you wait, and some people have shown that up to 18 months you may wait for the radial nerve. But what we do is, we do for the nerve conduction test, we do the EMG, and we see if the regeneration potentials are not there, then we go for early repair.
Thank you, sir. Thank you. Now we are going to start next section, and I'll request Professor Vineet Sharma and Professor Jagannath Sahu to kindly moderate this session. Sir, please.
Good afternoon. I think after a good first session, we start with the next session, and we have got 4 lectures on OT discipline, bone tumors, and principles of management and evaluation of hand injuries. The first speaker, I'll request Professor D.K. Taneja to enlighten us with OT discipline. Professor Taneja, please.
Dr. Taneja.
Thank you, Vineet. Thank you, organizers, for giving me this honor of interacting with my postgraduate students. The subject that I have been given is a very basic subject. And when it becomes too basics, the students tend to ignore. And so does the consultant tend to ignore. And I'm not surprised that even some of the basic questions are even not known to the senior surgeons. This has a lot of implication. Since morning, you have been hearing very good lectures from a very eminent speakers. They have talked to you many good operations, but just tell me one thing, that by one simple fundamental mistake, if your operation gets infective, what happens to the patient and what happens to the you? This is the very basic thing that we tend to ignore. And I always say that when you are talking about the operation theater, I always say it is your temple. When you go to the temple as an ardent believer in Almighty God, आप उस श्रद्धा के साथ अपने आराध्य के पास जाते हैं, इस आशा से जाते हैं कि मेरी मुराद पूरी हो जाएगी। और वहां पे जो नियम है मंदिर के, उन मंदिर के नियमों का आप पालन करते हैं। In the same way, when a patient comes to so and so surgeon, he considers you nothing less than a god. And he believes that I'm going to so and so surgeon, I'm in the safe hand. And therefore, my mentor, my teacher, my guide, my philosopher, Padma Bhushan Dr. Mukhopadhyay always said that in the life of a surgeon, the safety should come first, the excellence should follow. What is that surgery that you have done that you land up with a complication in a patient? You have injured the nerve, you have caused damage to his vascularity, you have damaged the periosteum, and the patient has landed up an infection. Therefore, the most important thing that a surgeon is afraid of is what we call, in today's jargon, is a surgical site infection. What we used to call it a post-op infection. So that is the basic objective of your surgery, that your patient should not get any infection, should not get any cautery burn, should not get any anesthetic complication. Not that you have done the surgery and patient has fallen from the operation table. What that type of a surgery, because in a consumerism where the litigation is going on every day, you have to be extremely careful. There is something called as legal and ethic responsibility of a surgeon. If you find a patient has got a surgical site infection, you have to treat it absolutely on a war footing. There is nothing these things. And this can only be done if you have done a good peri-operative care. You are very good at planning. Same operation you can finish in half an hour if you have planned it well. You have drawn the diagram. You know what position of the table, what incision, what will be my approach, where I am going to cut it, what osteotomy I am going to get, how I am going to fix it up, what is going to be my post-op management. Same operation, which we should finish, and if you have not planned it well, it may take you 1 hour, 1.5 hours, and 2 hours. As the time of the surgery goes on increasing, the chances of your patient getting infections goes on increasing manifold. If I ask most of you that what is an ideal post-op infection rate, most of you would not know it. What are the international expectations? And it is less than 1%. Can you get a 0% infection rate? The answer is, can you get a 0% infection rate? The answer is no. John Charnley tried to achieve a 0% infection rate. He failed. He said it is not possible. But if you have a less than 1%, it is good, and if it is more than 3%, it is a matter of inquiry and concern. We did some national survey on this thing, and you would know that in majority of the hospital in the country, in India, the infection rate, where I can say reasonable standard of operation theatre is between 2 to 3%, and not less than 1%. The prevention is always better than cure, it is well said, and therefore you should always try to have a very high level of standard. You should try to find it out your own auditing. What is my infection rate? What is the infection rate of my unit? What is the infection rate of my department? What is the infection rate of my hospital? Unless until you know these things and you maintain a chart in your department, you will never be able to know what is your infection rate. The surgical site infection therefore depends on some very important factors, like longer the operation, whether the case is an emergency, whether the patient's overall general health is good or patient is compromised patient. Therefore, one of the most important things is that by simple maintaining an OT discipline, you can reduce the infection rate in this patient. In last about, I would say, 45 years that I've been in practice of orthopedics, I have seen from a 100% infection rate to below 1% infection rate. How have we improved this thing? By simply, not only by OT discipline, we have now improved our operation theaters, our infrastructures. And now, wherever you go, you have got a modular operation theaters. One of the best operation theater you can get is OR1. And OR1 theater costs about 2 crores of rupees. And you will be surprised to know that even the smaller towns in the countries are now having a OR1. If you see those OR1 theater, you know where you have come. Everything is by touch screen. You do this thing, everything opens and everything opens. Few things that you must do as an individual. You should be, when you are in the operation theater, have a minimum movement. People are moving here, moving there like a Machli Bazaar. Minimum talking. People talk so much, people sing so much. Door is opening this way and that way. People are using mobiles. The anesthetists are talking. There are no proper masks, no proper cap. Though you don't realize that this all is adding to your infection rate. With all these things, what happens? There is a turbulence in the air. And because of this turbulence in the air, it is the bacteria which go and get lodged at the area where you are operating. Now, this is called as a contamination. A contamination of the wound does not mean that patient has got an infection. The infection starts when contamination becomes a state of bacteremia. And a state of bacteremia may go into a state of toxemia, it may go into a state of septicemia, and therefore a contamination, minimum contamination, and then cleaning that contamination should be your objective. Every operation theater, very simple thing that you can do, I do not know whether you know it or you have to have 5 zones. If you do not have 5 zones, it means you are breaking your OT discipline or your OT requirement at some stage or the other. As soon as you are trying to enter the operation theater, there is a white line, which called as the white zone. Start there, the OT discipline starts, you have to be very silent, put your mobile onto the vibration mode and remove your shoes. And then as you cross that white zone, you try to go and remove your shoes and put it at one place, and then at that very area you have a reception area. Now that reception area is there where your OT receptionist nurse will be there who has to do a checklist. If they are not doing the checklist, you get into a problem. overall responsibility becomes of a surgeon. If something goes wrong, it is the overall responsibility of a surgeon. They won't say कि वो कहेगा आपने क्यों नहीं check किया. Although it is a distributed responsibility. Has he wearing the OT dress? Has the patient has been taken a bath? डेंचर है कि नहीं है, स्पेक्स है कि नहीं है, कोई रिंग तो नहीं पहना हुआ, कोई ऑर्नामेंट तो नहीं पहना हुआ है, प्री मेडिकेशन हुआ है कि नहीं हुआ. What we have in our hospital, it is a type checklist, and she has to say yes, 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 and sign it. You must get a signature, and then take the patient inside. Usually the people don't take the history about the drug reaction, etc., and that's it. After the white zone, you go into a yellow zone, taken as OT sleepers, and that is where you have a doctor's change room and you change into a proper dress. We'll tell you what is a proper dress and how it should be worn. And from there, you enter into a blue zone. Blue zone is one where now you put on to a second line of slipper. So from first slipper, you put on to the second line of slipper. Now you are entering into a called as a high sterility zone. And you can see that, and we recommend very much that you should try to put on a gum boots rather than ordinary slippers, extremely important. And you can see this is the red zone. You are going into a high sterility zone. The OT nurse and OT supervisor has to be absolutely strict. In our operation theater, we have written this thing to make the surgeon very conscious of the fact, and this is true. We say the infection rate is being monitored. We expect your cooperation in this matter. Because unless you know this thing, and from in a red zone area, you go into a scrub area. The scrubbing, how you do a scrubbing, is extremely important. How many minutes you should do a scrubbing? Anybody? 10 minutes, 12 minutes, 1 minute, 2 minutes, no scrubbing. Huh?